And we're live? Good afternoon, ladies and gentlemen. We're here in the surgical room at the Guide Institute in Los Angeles, and we're going to treat a patient today and help him in the posterior mandible. The lower right area has a failed implant, as you can see here. This implant had been in place already for some years. Go down. You can see here on the CT scan how this implant had a severe bone loss vertically and horizontally. The next step was that we removed this implant, as you can see here, and leaving like a large deficiency. Next step. Here you can see on the reformatted CT scan, almost on the mental foramen, but a beautiful bony peak on the anterior and a good bony housing on the posterior. So we'll remove some of the bone on the distal, and then we're going to graft the anterior part with that large vertical defect and place a titanium reinforced membrane. Forward. And here's the condition. You can see here, here's good healthy condition, very nice clean periodontium. Everything is nice for the rest of the teeth except for in the posterior. But we're going to have to address this little thin area of carotid gingiva through a very careful placement of an incision. So we're going to get started now and then go through the steps that are necessary to treat such a challenging case. So that's your vertical defect. What's noting here is obviously it's like a really nice bone peak on the distal of the first premolar. Then it dips really down deep. And in the posterior also good level bone platform. And then what's noting here is that we have really a little band of carotid gingiva, which I'm going to try to maintain on the buccal and lingual. So we're ready for the first start. So we'll go for the 15. And let's see how we can show that. I need some gauze here. Let me go posterior. Okay. Tissue is really thin here. Trying to find the keratinous tissue. Now going anterior up the ridge towards the natural tooth. Sockler, elevating the papilla, and then making a vertical incision, slight diagonal, now on the distal, I'm going to extend a little bit more posterior because we're going to have to harvest some of our autologous bone. Now I'm going to move my direction buccal, always staying in touch with bone. Good. It's ready for the jaw one. Now my next instrument, here's the the jaw one. No. Yeah. Here's the jaw one. So that's my go-to after I make my incision for my U3D instrument kit. So I'm going down to bone, and I'm really trying to get through all the fibers. You can see the movement. I'm starting to make the first step into the elevation. My goal is to have a really clean, full thickness incision. A little bit of pressure there. This is going pretty nice because I have good carotenoid. You get a suction here. I cannot see here. Chin down, chin down. And I need some light here. I'm dipping into the biggest part of the vertical. Suction. Very careful here because it's difficult to get in this thin tissue. You feel a little bit there? Some pain?
Are you in pain?
A little bit? Okay, let's go anterior. Prepare some more anesthetic.
It's ready.
Okay, let me have the smaller elevator. I have here like a small, almost like papilla elevator, just to be able to get underneath. I want to be really full thickness on the lingual. Not easy here. The flap on the lingual is really thin. I might also have a little bit of soft tissue ingrowth in the area where the old implant was, so I have to get underneath it. What's going on here? Lingual is starting to loosen up. Go a little bit to the left. Which way? This way?
Yes.
Okay, I'm lingually. I have released the flap. I'm still full thickness, so that's good. Now I'm going buccal. Again, it needs to be full thickness. Suction here. Maybe ask Mariana. What would you like to see? Okay, suction there. I'm getting my buccal flap. I'm a little bit difficult to see where I am. because the dip is going so far apical, and I don't want to have any risk for soft tissue perforation. Let me have a Pritchard. Once we get the soft tissue elevated correctly, we'll be in a better position. Okay, this is bone. I already elevated the part distal of the tooth. Now I'm just needing to get into the part where the old implant was. Where's plier? Suction there. Okay, I need to have to cut it a little bit because the fibers are entering into the area where the old implant was. Section there. You might have it now. Yeah, got it. Okay, so my stumbling block was just like the area where the old implant was because I got all that soft tissue to invaginate. So now we're going to continue. This is my full thickness. Then here we're going to the vertical dip. The mental foramen is here. Yeah, I can see it right there, suction there. Can you see the mental foramen there? Right there. Yeah, that's the exit there. So right here in this area. So now I'm going to continue. So now I have full thickness all the way to the ramus. Let me have a 15 again. I'm going to make the incision a little bit longer than distal so we can harvest the necessary bone. Sorry. Okay. Always careful here with the, yep. Give me some irrigation. You can see the buccal flap now completely exposed and the mental foramen right there. You can see it. Okay. And now, of course, when we place the membrane, we're going to have to like cut it in such a way that it's not going to get in contact with this, and we're going to move it in such a way that it will fit towards the lingual. So the whole buccal is exposed. We're good there. And let me see on the lingual. Put an instrument here on the lingual that gives me like a little curve so I can get towards the mylohyoid ridge. Here's already the dip. It's going lingual as an undercut. The anterior is a little bit more straight. We have a 15C and a mirror. No, it's small. We'll go circular.
I don't think we can see behind the tube.
Hmm?
We can't see any visual behind it.
No. Mm-hmm. Difficult to. Feel a little bit? Okay, remove some more anesthetic. Okay, we got pretty much a big part done. Mm-hmm. Take instruction again. I'm working on the lingual flap. I'm going to be releasing the lingual flap right away because I'm already below the mylohyoid ridge. So with my instrument, I'm pushing right away through the periosteum, and I'm lengthening the lingual flap already. See how the lingual flap is already coming up? Can you see that? So here's the lingual already. Releasing it interiorly. I'm underneath, right on top of the mylohyoid ridge. That's good. Okay. So now let me have the surgical spoon. Clean out the ridge a little bit. I got a little bit of soft tissue in that big vertical spot. So I'm going to remove all this soft tissue. Give me a retractor on the buckle. Maybe like this, right there. But be careful, don't come anterior, because that's where the mental foramen is. So now removing the soft tissue, also cleaning the distal of the premolar. We'll place an 10 screw here. We'll need a straight handpiece to make perforations.
Ready?
Okay.
You have keys already for you too. You have keys already.
Okay.
You can do that.
And I use my back action. This is now just to prepare the ridge. That's all clean. Okay, I got that. Let's go. Next step will be retract the tongue with this tongue, really. Like this here. I know I need suction. We use the suction. And next step was the Pritchett.
I have it here, Dr. But there's enough.
I always have 2 Pritchetts in my kit. So let's go and show the whole site. So it's pretty large area, but everything is loose at this moment. And I want to bridge that defect. And go somewhere the membrane from here to there. So like, let me have a periodontal probe. So that's about 20, about 30 millimeters long. And then of course I need to go all the way from the lingual towards the buccal. So 30 by probably 40. So what's the membrane that we have? Can I see the membrane? I can start harvesting some bone here. And we'll take the bone scraper. So
30 by 40 and 40 by 50.
so let's start with a 30 by 40, yeah. I need a larger bone scraper. So this here is the micros. But for the posterior area, probably need to change this to a Pritchett, not to a Minnesota. Because I need to get in here like this. So here's my micros. So I'm going all the way to the distal. And this is like posterior to the area where we're going to graft.
You're good there on visual.
Mm-hmm. Okay, so now let me show you the amount of bone we have here. Some irrigation.
There's some bone there too.
So that's really the amount of bone we've collected initially. It's already in there. Put more. Put this one in here. I'll show you now the second scraper so you can see the difference a little bit. Here's some bone as well. And I put in the second scraper a little bit of saline. Okay, I need to get in here, so I need to, maybe even that bite block needs to remove so I can close a little bit.
Ready to get him out?
Yeah.
Let me touch him for you a little bit. Okay, open.
Okay. So this is the largest scraper. And can you remove what's holding me back here?
Just a lot of pressure, Mohammed.
Suction there. Just a lot of pressure. Can you hold this one here? Hold this one here. Close a little bit. Close a little bit. Yeah. Jump it so. Okay, so you can see the amount. Okay, let's put this in the wrapping dish. It's too much water. Okay, put it in the camera. Yeah. Okay, good. So you can see that's a really nice amount. Okay, we can go back again.
Pressure.
Taking it here from the external ridge. We have the metal one. Why is this open? Can I have the metal scraper? Just opening a little bit.
Pain?
Just a little bit of pressure. You can take that bone out. Okay, let's see how much we have. Dap and dish. In the, okay, good. So that's our, what is that, third pass? Fourth pass? Four, so we have 4 passes. I like actually the metal, just in my corner here. I like the metal harvester better. Gets less volume than the other one, but the application is more efficient. Okay, one more. I'll check here now if that's enough. Let's see. That looks pretty good, solid. Okay, we'll go maybe another 2 times. Some irrigation. Hold this one. Okay. Let's see how much we have. Dap and dish. Sorry. That was a good pass. I think I got the angle now. So we'll do one more, and that should be in it. Okay, let's do the same thing like we just did. Okay, hold it here. Don't section some bone there, okay? Okay, let's lower. Last dap and dish. Okay, now you can fill it up with just a little bit more saline water. Okay, so we're good with this. Now let's get some perforations. So I need some.
Can I put the bed block back in?
Yeah.
Open for me.
Okay, retraction.
What do you want me to use for keep retracting back here?
Yeah, I need to go here. So maybe the anterior. Go a little bit left. A little bit left.
Maddie, can I get a mirror?
Yeah.
A what? A mirror? And a Minnesota, please.
His tongue, retract his tongue here. Come on this side here.
Hold on, Dr. Taking this.
I think you need a mirror. Okay, so here's my straight handpiece.
Go in the back. Go in the back of the mouth.
About a 1 millimeter drill. 1.2. Very cortical surface, so careful here again with the mental foramen. A little bit to the left. A little bit to the left. Perfect, yeah. Okay, and press. Okay, you need to retract it flat. It's too big. You need a Minnesota. Yeah. I'm going to go and make some perforations in the occlusal surface where the old defect was or where the old implant was. That's actually all closed already. So I just want to Okay, we're good with this, so like we're gonna show that. Need a second Minnesota? Second Minnesota? Yeah. Make sure, careful with the mental frame. Huh? We can take a photo. Yeah. You just retract it and you can take a photo. Okay, retract. Okay. So mirror, give me a mirror so we can show that. So now actually the ridge is completely ready. Occlusal. Your hand's in the way. Other hand. Okay, you can see all the perforations. You can see the nice, clean, full thickness flap elevation. And of course you can see the mental foramen. And the bone we took all the way from the posterior, so no problem. So that seems to be ready for us to start preparing the membrane. And we'll probably need like a good ½ gram of xenograft. Okay. So we can open the xenograft and then let me have the membrane so we can start preparing it. Okay, so you want to take a photo of this? Okay. So let's do it like that. Yeah. And she can come in like that. Careful, just like that. Perfect. Yeah, that's good. Can you get in there? just going to move a little bit to the right. Yeah, perfect. A little bit more the tooth. You can get the tooth. A little bit more to the right. Perfect. We're just taking a quick photo. So we have a documentation of the defect. Okay, that's good. That's nice. Yeah. Okay, good. We're going back on video. And remember, we wanted to put like 110 screw on the crest. So I need to switch to a regular hand piece here. And I want to have a 10 screw. And we have already like some perforations here. So I can probably place it in one of the perforations. Right there. Maybe this one. Okay. Okay. I made like
Use that one for the handpiece.
I made a bunch of perforations in the crest in where the defect is, so I can use this one here as an entry. And I'm just looking at the vertical. So you're looking here, that's quite extensive. If you look at the from 5, 10, so it looks like almost to be a 10 millimeter defect from to the anterior bony peak. To the posterior, a little bit less. So we're basically going to have the bone level a little bit. It will go from super high anteriorly to like moderate in the back. So we're going to go with something like this. I'm not going to try to regenerate more bone on the posterior. I'm just going to fill in basically this void that he has. Okay, we're ready for the 10 screw. I can start already trimming. So let's get from here through. Okay, you can just hold this one. Yeah.
You don't need to hold it.
No. Hold this one. So you can see that. And I'm going to start trimming the membrane. So that's your membrane. That's the cytoplast, titanium reinforced, and so I've got a 150. This 10 screw? I'm
Yeah, do it.
Do you want to do this or handpiece?
huh?
Do you want to do this or handpiece?
Handpiece, yeah. So the spine is about 20. I don't need to take care of anything on the distal. I just need to trim the anterior.
That's good. 80, 50, yeah.
And then we want to build the ridge so you can see the width. That's 15. That's a lot of bone. We don't need that much. So I'm going to trim.
You okay? Mm-hmm. Okay. You're doing great.
So you can see like a little, I left the posterior completely intact, so we can possibly move a little tack or screw here to move it down to the bone like this. This will be to the anterior, so somewhere between the canine and the premolar. This will go around the tooth and lingually to stabilize. Okay, so we're done with that.
Okay, back to all one.
So
All one, yep.
we'll go to place the 10 screw.
Nice.
Okay, I can take that one. You can retract the lingual a little bit. Okay.
Can I get a picture, please?
And here's the 10 screw. So, what's the tallest 10 screw you have? This one is too short.
See, there is a 10, Bella. This is 10. This is 10.
Give me a.
This is 10, Dr. Joy.
This is 10?
10, yeah.
That's not a 10. You give me something taller.
It's an incorrect
Hmm?
Maybe it's in the incorrect slot.
And I'll place the membrane first, fixate it on the lingo, so we're going to have to fixate it like here, somewhere here. And then this one will be tough here in the anterior. Okay, ready? Yeah, that's taller. Okay, so here we go.
The other one is safe. Ah, okay.
So you can see the screw. Okay, hold on. I'm putting it in such a way that it's. Huh? Looks pretty good. I can go a little bit deeper. Handpiece again. And place a new 15 and a new 15C.
Okay.
So we can release the flap. Okay, good. That's the 10 screw.
Ready?
Okay, so now we're going to release. So what we have to do is like you just hold this one here, just the cheek. Okay. 15.
Do you need to hold the lingual?
No. No. Let's release here. So I'm going to take the buccal flap. We need to suction. And I'm going to the base of the flap to start to release it. Got to keep it nice and dry here. Now I'm coming close to the mental foramen. Oh, sorry. The suction here, right there, where it's bleeding. Yeah, perfect. Can you see that, Tatjana?
Yes. Got a little water to put that?
Yeah, you can. Not in it, just from the top. You can give me water.
What?
You can give me a.
On the top, by the blade.
Don't put the syringe there, just the water. Water is like this. You can see the opening right on top of the mental foramen, but I don't see any of the nerve fibers, so we're good. I'm below the vestibular groove. Now I'm going to start to brush up. Section. And I'm holding the internal periosteum. And I'm splitting just below the periosteum and going upwards. Into. Yep. Give me a little bit more anesthetic. Let's see how the flap is doing. We're going to check how the flap, retract the lingual, so I can see. I'll have this. So here's my buccal. Checking already how. Oh yeah. Look, I have like, the flap is completely loose. And I still got room to go. But it seems to be already completely loose. So I'm going to release a little bit more the posterior. Anterior where the ventral foramen is, looks like really good. So, you see I can bring the flap all the way coronal to my tooth position. Okay. Let's see this one. Section there. Okay, sorry. Okay, let's go to the posterior. Looking pretty good. Tongue. Section there. I haven't released the posterior yet. So I'm going to get there. I need to retract the tongue from this side. Okay. Section. Anterior. We might be done. Okay. Retract the tongue again. Yes, sir. Give a mirror. I don't think the tongue goes with the Minnesota. It's too hard. Just like here. Relax. Okay. Not easy, we know. So I am in my last phase of just checking that the buccal is completely released. I'm concerned about the mental frame because that's often where it hangs, but no, this looks loose. You can see here, I can move this. Yeah, if you can keep your tongue as still as possible, it would be a hard one. I know it's hard. This is all loose. Okay, good. We got good bleeding from the periosteum, so that's good. Okay, let's start trying to put the membrane in. So I need buccal release. I need here all hands on deck here. Okay, like this. And you need to come here. And I need here, yeah, this one. Actually, if you can put this one and this one, then she can suction. But be careful with the mental foramen. Okay?
Keep this one in the bone here.
Yeah. Here's the mental foramen, okay? So this needs to go more back, and that needs to go more front. Okay, that's good. And let's see how the membrane will fit. So that's your membrane. That's the space. No. We're going to tease the membrane underneath the lingual flap. Suction in the buccal. Now the distal seems good, so the length is perfect. And so if I can move it like this, and then we can put this one here. Oh. So I like the position of the membrane, so that my kind of just eyeball visualization and knowing these kind of defects works for me. So I'm okay. So now it's just a matter of how do I get a screw in here. So I can get a screw here. Probably here. Right here. And then so we leave this in. You keep retracting. I will give me like an probably a tack. I can yeah, give me a tack. Let's see. Okay, membrane is in position. So now it's like this is the easy part. The hard part will be now to get it to get a screw in here. Okay, hold this. Yeah, hold both. Be careful again with the mental foramen. So touch me. Let's see how that's on the mesio. That's good. So now, there's going to be a little bit tapping on your lower jaw. Hold this lower jaw. Yeah. Okay. Tongue, hold your tongue still.
Just tapping.
That's fine.
Are you in pain?
It's just like a little bit.
Discomfort?
Okay, so the tack did not go into the cortical bone. So usually what I do is I just try it one more time. Because the tack will be easier once it fits. Okay, this needs to go underneath here. You got to get with this one under the flap. Okay. Where's the mental frame? Okay, so I can see the mental frame is right here. So I got to cut here like a semi-lunar, just so I can let the Okay. So I just cut like a little piece out of the PTFE to allow the. No, that's not. Okay. Here we go. We're going to retract again the. No, it's not going to work. Okay. So I kept the membrane open where the mental foramen is. And ready? Here we go again, tacking.
Just relax.
There we go. So second take we did it. So now I need a screw on the handpiece. So we're going to have to get the membrane into the lingual of the premolar. Oops. The short one, the short screw.
But thinking.
Okay, now let's hold this one. You can hold it like that. Membrane will go here. Okay, now I have to get here. Yeah, you have to take your retractor away. Open as wide as you can. And where do I go? Somewhere here. Okay, if I can get down there. Let's see, handpiece. Now this would not be possible without the handpiece, because like I need to get lingually. I need to squeeze past the tongue. Okay, let's see. I need a mirror because I cannot see anything. So maybe a small mirror. I want to see the screw where it is. So okay, so the screw's in, but I don't know exactly where it is. So wait. Just hold this one here. Let's see. Sorry. Mirror. Okay, the screw seems to be in the right position. Double check again. Yeah. Yeah. Okay, it's like right there. I don't know if you can see it. There.
Oh, yeah, yeah. Here.
Okay, there you go. So that's I did that blindly because I was just like estimating. But it moved in there, and it's stable. Let me just double check because I don't want these screws to come loose because then we have no more stability. So light, I need light. Okay, good. So tongue, we track with the mirror, the tongue. And then we're going to go here. If we're good, you have to hold here. Okay. Now let me see. Okay, I'm just checking if the membrane is stable. It looks to be stable, yeah. So now I'm opening the membrane so we can start placing the bone graft. Okay, hold on. Like that. So here's the membrane, here's the defect. You can see how the membrane, I don't know if can you see how the membrane is on the lingual? Yeah. You can see the membrane on the lingual. A little bit to the left, a little bit to the left. Left, perfect. Yeah, stop. Look. So you can see how I build a wall with the membrane, and that's kind of your new bone wall. And it's fixed on the anterior with the screw. And it's stable, and it's fixed on the distal with the pin. So now we can start dropping the bone in. And we have, obviously, a lot of autogenous bone. So that's quite a bit. And I'm starting off with 0.5 gram of bios, but like that's probably 2/3. So right now I'm like easily 70% autogenous and 30% scaffold. Okay. And now we're just mixing this one. You can see I'm getting quite, I don't know how big this vial is, how much volume there is, but I'm coming to at least half of it. give me maybe like another 1/4 gram of the biomass. Then we have like a little bit more volume. So I have a lot of autogenous. So I'll do like a 0.75 gram of scaffold, so xenograft, and then the rest is all autogenous.
0.25.
And then we probably can put a tack here.
Yeah, I put one there, one bone.
Okay, we can do a tack here, and then a tack here. We'll just do huh? Half? Okay. We have only 1/2 gram, so I'll just take about, you can maybe take the camera, just to show the...
To do this again? Okay. Not yet happy, but soon we're gonna-
And when you're done with this, you can bring me some Emdogain.
Okay, Tuffy, all three. Yes. All three.
So this 1/2 gram, so I'm just gonna use,
Patsy go or should I go?
huh?
Can Patsy go?
Whatever. That's good. We have a little bit extra left. I have a feeling this is going to be enough. So that's quite a bit of...
And just so you know, we're gonna have to switch to the other. Just get this another pause, what we put it on, and then we get back to you.
Okay, so, yep, you can do it now. So let's go to the retractor. We're going now back to the oral cavity, and now we have to like retract, and we have to really retract well. I have to open the membrane, and we have to start condensing the bone. So I have a plier here which is has no teeth, so that's good for the membrane. It doesn't traumatize the membrane, and you gotta go here under the flap with the retractor. You gotta do the retraction under the flap. Okay, like that, and then we need like another retractor. Same you had before. No, she has to do it. Okay, that's one. There's two in the front. Okay, perfect. Okay. Now, how's the visual? So you can see the tan. You have, don't suction here anymore because we want the blood to come in here. Just be careful. Go more at the front here. Yeah, perfect. Here's my mental frame, and I'm always careful with that. And now I'm going to start to drop the bone. How do I do this?
Can you hold it?
Can you?
Yeah. I'm not using my suction in the front.
Okay. Yeah. You see the bone?
Yes. Good visual.
So I'm going to drop the bone lingually. And I have on the same instrument, I have the condenser. That's what I call the Joe 5. So I can nicely condense it against the membrane. I've got some blood there in the back. It's fine. I'll get it to the front. I did a study many years ago, very same technique, but just with a blood clot. And even with a blood clot for small defects, the bone can grow underneath the membrane. So the scaffold that we're giving, it makes it just more powerful. But you definitely want to get blood in there, which we did the perforations for. You can see that our harvest was great.
Can you section at the base of the bone?
You know, yeah, a little bit, but not too much, because I can use that blood. Saliva you can for sure suction. So now I can use the membrane just to position the, so you can see how that looks pretty nice. The width, so let's see what happens when I open it. See, it looks already like almost like we regenerated it. That's the beauty of this combo of autogenous and the xenograft, because it really gets, and with the blood, it's like very much sticky. A little bit of bone here in the front. Yeah, I used all my bone. Okay, so now I'm going to have to get like a pin. Wait, let me just hold, stay like that. Put the membrane down. Yeah, okay, suction there, suction there. This way. It's over. Okay, a little bit to the left. I'll take this one. The front one you can let go, or give it to, yeah, we don't need that anymore.
Can I remove?
Yeah. Okay, give me a pin.
Okay.
So here we go. So, the bone is there, and I can put a tack somewhere here. Yeah. 1 second. You gotta hold this one. Hold this one. Right. Yeah. Perfect. I got
More
this.
tapping,
I got
okay.
this one. I got this one. So I'm going to move the membrane down so it's in a nice position. Yeah. Okay, it just came loose. Yeah, I got it. So I'm pushing the membrane down, so I just removed the tack from the holder. Yes. Can you give me another one? Got it?
Ready.
Suction it.
Where about his instrument then?
Okay, so I have to do it. So you have to hold this one. Okay. Hand down.
Tapping.
You're going to get some tacking.
A little bit more, Dr. J.
Okay, got it. I got it. Okay.
Another.
Can you see the second tack there? So that's the advantage of having a lot of PTFE, because I can move that membrane all the way down. Here's nicely sealed, no space, open. Give me like a periodontal probe. You can see that's a nice seal. The width. Now we have to do the anterior. Okay, a little bit to the left.
Keep moving, so
Hmm?
I'm not
Yeah.
going anymore.
Careful with the mental. Where's the mental? We're going to have to use a collagen membrane. Okay, another pin. Can you section that? Just like in this spot here, where I am? Just where I am. Yeah, perfect. Okay, how's that? A little bit open on the anterior, but we can do that with a membrane. Okay. Again, a little bit tapping.
Tapping. Can I release?
No. Okay, got it. Okay.
Another pack? Or no?
Yeah, don't know. Okay, just checking in on the membrane. Yeah, we can do one more tack.
Ready.
You can open me like an collagen. Can do a BioGuide, like a small one, like a 13 by 25. But I need first here, because I need to tack. So come here. Retract this one, the back. Okay.
Tapping.
Got it. Okay, so we have 3 tacks on the buckle. And I just have a little bit of, I like the front. The fixation is good. I got an opening here around the mental frame, and that's good. The seal in the back is, yeah, I would say perfect. So the only place where I need like a membrane to cover a bone graft, okay, can you see that? Here's the whole membrane. So I'm just going to cover a collagen right over the mental frame, or just below it. And then here in the front. Do we still have a little bit of bone? Retract the lingual? Or do you have some bone?
I need a periodontist. Retract the lingual.
Yeah. Put it down so you can use. I need like you to push it down with an instrument. You take one, yeah. Okay, okay. Mohamed, we're getting slowly to the end of the procedure, okay? Okay. Let's do a mirror so we can see the occlusal.
Ready.
Okay.
There we go.
There we go. Yeah, that's good. Yeah, zoom in. Yeah, perfect. Okay, so it's, you can see it's like really nicely stabilized. It wasn't easy, but we got it, and it's like, looks, you see the width. So once we get this done, the width will be like, you could easily place a 4mm implant diameter, could maybe even go bigger. But first we have to get there. So that's good. So let me have the membrane. Yeah, that's good. Okay, I'm going back again here. Now let's see how the flap will close. You need to like retract the lingual. Okay, you can see the buckle. That's good. Oops. Yeah, we're going to give you a little bit more anesthetic. So here's, this is closing. It's closing. Lingual? I need the lingual flap. I know where it is. Need to find the lingual flap. Get over here. Okay. We have some anesthetic. Starting to wake up here. Here's the lingual. It's coming all the way over the ridge. Look. So that'll give me a nice. Okay. Yeah.
Giving you more anesthetic.
And you can start giving me like a 3-0 cytoplast suture. Okay. And yeah. Just wash. And let's place the collagen membrane. So I need a retractor in the back. Right here. Hold the back one. Hold the back one. The back one. This one. That's fine.
Can I touch one at the base?
Hold on a second. Okay, a little bit left, a little bit left. Okay, now suction there. Okay, you hold this one. So that's your collagen. So you're going to cut it a little bit. No, it's not worth it. So that's the BioGuide. It's about 1/2 millimeter thick, this one. The other ones are a little bit thinner. Thickness gives us also a little bit more stability. So it hydrates right away. So I'm covering that area where I made a little opening for the mental foramen. That's good. Okay. So now let's just do the cheek because we're going to start suturing. Okay. So now suction the distal of the membrane.
Anterior or posterior?
Posterior, but don't suction the bioguide. So posterior, posterior. Okay. So, okay, ready? Hold this one, just the cheek here. These two, okay, but the cheek, okay? That's good. Where's the end again? Okay, we have the end again. So I will inject that. I will start first to suture, but I can show you just like how we want to apply that. Tract a little bit. See, it's a gel. I'm going to leave that just before I close. I'll do more. So now I start the suturing. And I'll start like right. I'm going to reposition the anterior just so I have a good visual where I want to go. So we'll put this one here first. Because sometimes in these big flaps, especially with vertical incisions, you lose the correct. My knots are 2 knots first, or 2 throws. Then 1. Then 1. And then 2. So 2, 1, 1, 2. Do more at the bottom. So that's the same suture that I will use on the crest. That's the 3-0 cytoplast. Okay, now we're going to go to the crest. Normally I always close the crest first, but in these big flaps with a lot of loose tissue, I like to just have a reference. So let's see. Yeah. Your chin down, chin down, perfect. Yeah. Now I got to grab the buccal and find the margin. Here I am. And that's my distal, so something like this is good. I'll go deep. It's probably like 4 millimeters. Now I got to grab the lingual. Oh God, open wide. Yeah. Where are you? Okay, I got it. Again, also in the lingual, I'm going deep, meaning like about 4 millimeters from the margin. Now I'm coming back from the lingual. And I'm going to exit the buckle. Okay. Now let's see what's going to happen. My mattress is done. And here's my closure. Okay. A double throw. Single forward. Single backwards. And double forward. Can make it long. This suture will be embedded in the tissue, so good. You're left-handed, so. Okay, so we're good with that one. So the first one is sitting pretty well. Let's show the mirror. Mirror. Good, that looks like it's nicely eversion. So we'll continue doing this. So we'll probably place like a good 4 mattress sutures. And I can inject a little bit of the Emdogain already here, just underneath the flap. Okay. And the second mattress. Got to grab the Lingual. And again, I want to get some thickness. Okay, that's good. Okay. Here we go. You can see my suture is completely in mucosa because I have no keratinized tissue. But the flap is nice and thick. So look, now it's everting. You just saw it pop.
I saw it on the video too.
Yeah?
There's a question for you.
Okay.
Ready for it?
Mm-hmm.
Just repeat the question when I read it to you. From Hooksa. Does the collagen membrane compromise blood flow on the region that you place with the PTFE?
Does the collagen?
Does the collagen interfere with any blood flow?
So I just get a question from YouTube.
Yeah.
So from online, and they're asking if the collagen interferes with the blood supply. And I would say the answer is no. It's probably the contrary because the collagen is a natural collagen membrane, so it's very, very tissue friendly. And remember, the goal of that collagen was mainly to keep the bone in place, because we had a couple of areas where the PTFE did not cover the bone graft, so this will be like about 2 months of security, and but it will not compromise the blood supply. Okay, my next mattress. Now it's ready. The flaps are so nicely in position that I can just go from the buckle straight through, there we go, to the lingual. So that's one pass. After this suture, we're going to have to switch to a new suture.
Okay.
Tatiana, can you open already a new suture? Trio. There we go.
The doctor wanted to come here for 2 minutes. Is it okay?
No, he came in for a little bit.
Or she?
Oh, she?
Yeah, that's okay. If she wants, it's okay.
There we go. Another pop there. Mm-hmm. So we'll take a new suture. I can still use this one, but like I want to, for the mattress, and when I get in the back of the posterior, it's it will be like really hard to do with like a short suture. I think a 4th mattress, and then we're done with the mattresses. Mm-hmm. Good. Yeah, this is like, I just want to have a mattress or suction there. There's no membrane here anymore, so I don't even need it. But I'll do one more, just to be complete. So how many mattresses do I have? 4 or 5? Is this 5th?
This is the part.
One, this 4, okay. So we're going to place 4 mattress sutures on this quite long incision. There we go. Again, it pops it up. Retract the anterior leg. Mm-hmm. You can see the key to this procedure is really how much soft tissue I have coronal to the membrane. Okay, we want to now show the occlusal, retract the cheek. Yeah. Retract the tongue. Okay.
Water.
See, it's hard to believe how much tissue we got coronal, but you can see my mattress sutures are, well, they're probably like 4 or 5 millimeters below the incision margin. So now it's still not sealed completely because we need the single interrupted sutures, and I'll finish with that. But before I do that, I'll just go in with my syringe with the Emdogain and inject it. So you hold it there, hold this one here, this one there. So I'm going to go in here and inject the end again. A bit more distal.
Your hands on the way.
You want the mirror or this?
That's good.
Both, we have paper.
Okay, we're good. So I'm closing with single interrupted. Retract the tongue. Retract the cheek. Yep, cheek.
Need to go there.
Come from here. Yep. So now we're going to finish everything. And the goal with the single interrupted is to go really like a very deep suture, so I can really get underneath the flap. Oh, underneath, yeah, underneath the incision margin. I need some light. There we go. So that's a single interrupted between the two mattresses. One. Okay, I need to go anterior. I'm not going to go just distal of the tooth. Give me some suction here. Can't see the lingual. Where is it? Is it grabbing the flap?
No,
No?
I don't see it grabbing anything.
To check it. Where's the mirror? Can't see the lingual.
See it now. I don't know if it's.
Oh, no, it's good.
Yeah.
It's in the flap. Yeah. So I grab lingually the flap as well. And this suture will basically close the papilla distal of this premolar and seal the entry for any bacteria coming from the natural teeth. So this is an important suture. You gotta go with another scissor. This is because you're left hand. It makes a difference. Try this one next. Okay, now I'm going to take the papilla between the teeth.
There's another question on YouTube.
Oh, there we go. Yeah.
Just repeat the question, but it's, what will you prescribe the patient to reduce post?
Swelling.
Yeah.
Okay, so the question is coming in online. What do we prescribe to reduce swelling? So this is also for our patient, Mohammed. So we'll prescribe obviously an cold pack. Important to say we're not prescribing any steroids because this is a regenerative procedure and we don't want to reduce the patient's biological ability for regeneration. So we want cells to develop here. So ibuprofen is a good one, a non-steroidal anti-inflammatory. And maybe we'll give you some homeopathic. We like.
I really went through with them on the weekend yesterday.
So homeopathic, you can give arnica, it's pretty good. Here's suction here. cut. So basically, cold packs, ibuprofen, and arnica montana. Those are the three main things. Okay, this is good. It's good. This maybe here. I need this papilla. And I need to secure this top papilla. Mohammed, we're slowly but surely getting to the end. You're doing great, man. We'll give you at the end some anesthetic, so you go home with like some really good numbing. I'm on fire.
Ready?
Mm-hmm.
Okay. Considering the fact that PTFE can reduce bacterial adhesion into small pores, can you tell us what is your protocol of managing the early exposure of the PTFE
Yeah.
and later exposure of the membrane?
Okay, yeah. So the question is coming in here. What would we do with an early or late exposure? So pretty much both situations are similar. Once we see the membrane, so intraorally, we have to keep it like really as clean as possible, which means like we're going to give the patient an oral rinse with chlorhexidine, and we're going to keep the patient swabbing the area, just locally clean. Normally no need for antibiotics because there's no infection, it's just a soft tissue exposure. And then it's important to recognize that these membranes can stay exposed safely for about 30 days, sometimes longer, but 30 days is a safe one. And, but you can say, let's say 30 to 45 days. And then you have to go back in and remove them. And obviously you have to remove also the pins and everything. So it's a surgical work that we don't do unless there's a surgical complication. Late is similar. The only advantage of the late one is I prefer late exposures over early because the bone is already more mineralized and has more vital bone than when you have an early exposure. So the tendency is like when you have a late exposure, take this out, no, this here. When you have a late exposure, you're going to have less bone resorption. And early one, you're going to get a little bit more of your graft to shrink. So late is more beneficial than the early. Okay, cut. So we're slowly but surely there. Okay, I need another suture. Tatiana, I need another suture. Yeah. Okay, let's check. Let's irrigate. And okay, just with your finger, just irrigate. Okay, tongue. Yeah. So it looks to be already almost closed. So let's show in the mirror. Let's show everything. What do you think? Oh, here in the back, right? Yeah, in the back. I just need the back. Okay, show me. It's dark. It's dark. Camera. Chin down. Chin down. Chin down. Copy. Okay, camera. Okay, good. I think this is good. So I got single interrupted here. I got a mattress here. I got single interrupted here. I got a mattress, single interrupted. I close the papillas here. So I need like 2 more interrupted all the way in the back. One here between the mattress and one in the back. And that's it. So I think we can even like show this, and then we can close the online video. And okay, you got to retract here. Okay. So that's your closure. 2, 1, and then let's do a video. Okay. That looks really good. I'm happy with this. And just for the record, 2 more sutures need to be placed. Okay. We just completed the vertical ridge augmentation procedure in the posterior mandible using a combination of bone graft autogenous harvested from the ramus and mixed with a scaffold, a stable scaffold like a bovine xenograft, covered with a titanium reinforced PTFE membrane. The PTFE membrane was trimmed around the anterior tooth, around the mental foramen, and it was secured on the lingual with a screw that I had to use a handpiece on because it was very difficult to get it just the lingual of the premolar, a tack on the distal lingual, and then 3 tacks on the front. I released the buccal flap with like some brushing, as well as a small split thickness in the incision, in the periosteum, and I released the lingual, again with a brush technique and just being on top of the mylohyoid ridge underneath the lingual groove. So then we closed it with mattress sutures and single interrupted sutures, and in between the sutures I injected some endogain growth factor to stimulate wound healing, because obviously we have like about 10 millimeters of vertical bone that we want to regenerate, and we have about 8 millimeters or more of horizontal width. So everything looks good, looks primary closed, really nice coronary positioning with no tension. So healing time will be 9+ months, and suture removal will be anywhere between 2 to 3 weeks. So we're looking forward, and the patient, from my standpoint, will get a thumbs up for a good healing and a good result.